So describe a competency framework for training in GI endoscopy. We're actually not going to describe the whole competency framework. We're going to focus on the competencies within the room. So these are the way we actually train, the way we articulate and describe things. And within that, we'll highlight and deconstruct individual components of training. We'll discuss how these components can improve training and to provide simple tips and tricks to enhance training of everyday endoscopy. Well, it's probably descending sigmoid, I think. It's anything else?
Well, the other tight angulation, tight deflection.
Okay. So the other thing I notice is that if you look at the lateral border of the descending colon, it's bulging laterally a little bit. Okay. So then if I can, I'm just going to come around this side here. So if I put the scope here, it was along here, it was bowing along the descending colon there. And you've straightened it out a bit now. So just looking at that, I think there's one thing you can do to just make things a lot easier. What do you think?
Some left-sided abdominal pressure.
Well, I would put him on. I put him on his back, and what I want you to do is just appreciate the AP distance on the blue screen. So from the most posterior part of the scope to the most inferior part. Okay. So the posterior part is here. Okay, and the most anterior part is about there. All right. So what I expect to see when you flatten him or put him supine, is that distance will decrease, so that anterior bulging will lessen. But also you're applying 90 degrees of clockwise torque, and you need a bit of torque to just straighten the scope out of it. You may feel the scope pushing your hand a bit, and the scope will want to come out when you put him on his back, and that's the effect of the clockwise torque driving you back. So let's do that, please. So you take your scope away from his legs. Keep your knees bent, Mr. White, and just roll on your back. So your job here is to maintain the luminal view all the time. And just pull back very slightly.
Put the right leg over the scope.
Right. So you lift your right leg then, sir. That's it.
And then flatten the right leg out.
Straighten that one then.
So, thanks. So just, I want you now, Adam, just to look at the scope guide and just remember how it was.
Yeah.
It's strikingly different, isn't it? Because you've got very little anterior movement on the blue screen. You've got a much smoother run-up on the green screen. You've still got quite a tight angulation on the splenic flexure. But you're in a much better position to get around this first time. All right? Now, I would be inclined to put the stiffener on here. Right, we'll stop there. So I hope, when we play this back, you'll see that there's the contrast between John and me in that situation was there wasn't a lot coming out. I was having spaces, wasn't talking all the time, notwithstanding the improvements. I think from my perspective, I think on the learning objectives side, it's not unusual for someone who isn't trained in the sort of way that we train to not really be able to articulate what they need to learn. And I see that as a sort of failure of training. I think it's very important that we teach the trainees to recognize their shortcomings so they can. So in that context, I would have said, well, look, if you've got no learning objectives, my learning objectives for you for 600 colonoscopies is to improve your conscious competence because, and we'd explain what that was, because I know that you're likely to be lacking in that, all right? So we will be looking for opportunities for that. So here, I think there was a heaven-sent opportunity to improve her conscious competence. And I think my personal strategy would have been to say, okay, I want you to really interpret this scope guide and understand what's going on. And what it was more or less a complete loop. It had a spiral component. And I would have explained to her what she needs to do before starting it exactly what she needs to achieve to the point she's going to withdraw the scope so she can get it out first time. And then I would say this is quite a difficult and complicated maneuver that has to be done very slowly. And I think there will come a moment where if I think it's at risk, I will start throwing instructions to you, because at that moment she will probably find it difficult to compute and to do the scoping as well. So the question of the timing, Don, is really that moment where you feel as a trainer that there's just too much for her to do. And if you start firing instructions, that does impose an extra load on her, but it actually takes the whole decision-making load off her, and then she all she has to do is follow instructions. And then she'll complete the task, she'll feel very good about it, and then it's all on video, and she can deconstruct it later and then learn from it. And someone who's got the scope handling skills that she seems to have, she should be able to do that, frequently next time. So that would be my difference of approach. This is a bit irritating, the buffering problem. So the problem there, Don, is what?
What the problem? You want the problem or some other things I've seen?
No, well, the problem. So
well, the problem right now that I see is he doesn't have a luminal view.
Yeah.
Yes, he's correct about a long scope. Yes, he's correct about what he may have to do, but he doesn't have a luminal view. There. Assuming the lumin's down at 4 o'clock.
Yes,
so.
4 or 5 o'clock.
It's going to be hard to get round into the cecum with a long scope.
Yeah.
Because the hepatic's going to be quite tight.
Okay. So I think your main problem is going to be you're not going to be able to see where you can go. I think you'll be able to control the scope and move it forward with a bit of compression. But you're going to run into that fluid, and that fluid is a bit opaque, isn't it? So I'll just stop it for a second, and that may help the buffering. So Don, but just pick up the bits that you've heard so far. What have you, from the training perspective?
Sure. Well, there were some really nice things there that I saw. So, for example, I noticed, little less pressure of speech from the previous training.
Yes. Yeah.
I like the way you reinforced some of the things that he did, some good points. So, for example, you asked him about what the scope guide was doing, and he pointed out the tip going posterior, looking particularly at the lateral view. And certainly for trainees, that's often hard to pick up. The AP is a little easier than the lateral.
Yeah.
So you actually reinforced that was actually a good pickup on his part. So I thought that was actually very nicely done.
Yeah.
Because that's important to reinforce what they're getting correct as well as not just fixing the problems.
Okay. Mummy, anything else you picked up?
Yeah, I agree with you, Don. I think one of the sort of small things as well, I really like the way you move around the room.
Yes.
And you're getting the long view, so you're not fixing on the scope guide or his hand position. You're actually taking in different aspects of it to see how you can improve. I think that's something that
we call that the what?
The wide angle view.
The wide angle lens, the wide angle lens.
Yeah, that's what it's called.
It has a term, yeah.
Positive reaffirmation, as you said. But also one thing that I picked up upon, which you mentioned this earlier as well, it's really hard to get the communication right in PPE. And sometimes I struggled to hear, I know it's a video, I struggled to hear what you were saying.
Yes.
And I think we just should be cognizant of the fact that the room is a noisy environment with water pumps, suction, and sometimes people can't hear very well. So just actually slowing down.
Yes.
But something that's talking too much in front of a consciously sedated patient is also tricky. So I think you have to just work that relationship of how you communicate with the trainee and sort of adjusting it.
Sure. Good. Well, I'm famous in the unit for mumbling, all right, and at home as well. So I don't know why I do that. I can speak clearly if I need to, but I definitely mumble in the endoscopy room, and the PPE doesn't help matters. I agree. I'll come back to you in a minute. And is there anything you want to say, Paul, particularly?
Just, I thought what I liked was you were using the scope guide to really try and deconstruct the problem, and you weren't telling Adam what the deconstructed problem was. You were trying to pull out of Adam,
it out of him,
get him to work it out. Yeah. And then if he works it out and it works, then you've got complete buy-in, haven't you?
Yeah. And, Good. So you can't see it on the screen here, but my colleagues here have each got a piece of paper and a pen, and they're furiously writing stuff down as they go along. And it's one thing that we teach trainers to do, and particularly when we're training trainers and training consultants, we have a pad and a paper, and we're writing down everything we see. And that just enables us to recall everything. And it takes the pressure off us when we're doing that feedback, because we're not thinking all the time, well, what happened then and what happened then? It's all written down. and we can refer to it. So we can pay all our attention to the trainee himself or herself. What did you pick up again from that bit there?
Well, one of the things we haven't really addressed yet so far is just the concept of safety and our comfort as a trainer in terms of the safety aspects. And as I'm watching your trainee there, who you're saying has only really done 35 colons at this point, the thing that really impressed me was tip control was great. And I don't mean tip control in the context of, he can do all kinds of fancy things, but it was as he was going around that lumen, going around that flexure and that turn, which required a bit of a relatively complicated maneuvering. It was done very slowly, very safely, very calmly. The room was calm, you were calm, he was calm. And so from a sort of the atmosphere in the room and a safety aspect, that was fabulous. And then the next thing that I really liked is after he got around, you said stop, and he stopped immediately, which also I think for us as trainers, it reinforces our comfort with regard to patient safety, which of course is always paramount when we're training.
Yeah. Good, fine. Manmeet, anything else you'd like to point out there?
Yeah, I think it's important to recognise that you have a responsibility for that patient, but you also have a responsibility for training, and that's kind of sometimes a bit of a dual conflict. But when I'm in that situation, I just always focus in on the patient and maybe justify any action I might have to take so that it doesn't feel like it's a criticism or anything. The only other observation I made, I think at one point you said turn right or tip right, and one thing that we can do to sort of maybe think about the language is use hand signals, so tip up, clock face, so clock to the right, or so that it's easier for them to understand. So I think just thinking about those small things.
Sure. That's helpful. I think my top tip is less is more. And what I mean by that is choose your moments. For someone who's very consciously competent, you can see so much stuff going on, and really the trainee is only going to get 10% of it. And if you say less and focus on the most important things, then you'll be much more effective. But I think Adam's expertise is, I hope, a combination of his natural ability, but also